Thoughts. So hi, my name's Matt. I'm here as part of the I Hear Reference Research Special Interest Group. This is webinar number 3 in our joint series between the I Hear SIG, the IOPRA, International Academy of Health Preference Research, and the Patient Journal. It builds off a set of papers that have now pretty much all been published in the Patient Journal about best practices in health preference research. So we've taken the opportunity across IHEAR and IOPRA to get the big hitters in to come and talk about, these core aspects of health preference research. So Axel will talk in a second. He's going to present for about 40 minutes, and then we'll have some discussion. As with the other webinars, the content's designed largely for someone with pretty little or no experience in preference research to get the basics. But I'm also conscious that lots of us here have done a fair bit of preference research. Good to see some familiar faces in the room. So let's have a discussion. So let's put some comments in the chat and questions for Axel in the chat, and also when Axel's finished, we can have a discussion afterwards. So without further ado, Axel, let me hand it over to you.
Thanks, Matt. Thanks for the invitation, and thank you that I'm able to present. We wrote a paper for the patient, which was on how to present the decision object in health reference research. It was part of a series, a basic series for best practice. I wrote this paper with Esther de Becker-Grob, Olivia Rivera-Arias, Bennett Leviton, and Caroline Bass. And we started out wanting to explain how we could introduce the different methods and aspects in health preference research. So just a quick introduction that in health preference research, we're focused on capturing preference for health intervention treatments or services. So the purpose of this paper was to present practical guidance on linking HPR questions to decision models, attributes, and attributes levels. The overview or the objectives of this presentation and the paper was to explain the importance of decision models in HPR, how to define attributes and attributes levels, building a clear descriptive framework, formulating hypotheses based on that descriptive framework, and at the end, we can discuss some key limitations. To start off, what's the model and what's the decision model framework? So the underlying idea is that we present an object to subjects, which means the participants of our studies. So once we have these subjects interacting with our objects, which later then are the attributes, we can observe a certain behavior. And that behavior can be observed in multiple ways. People can rank, rate, or just even explain in a qualitative manner what they think about the object. So that's the underlying idea of using these terms of subjects, objects, the interaction between them, observing a certain behavior. And all of this is done in a certain decision context. So the decision context could be social, personal. It could focus on the regulatory environment within a clinical decision-making process. And within this decision model, we start off explaining what the decision context is. We do have to be clear about what are the subjects. Whom are we stimulating with our objects, attributes, or alternatives in order to gain information about their preferences? It could be patients, can be healthcare providers, could be other stakeholders like family, could be citizens, every entity which would be involved in the decision-making process. And we have to define the alternatives in order to grasp what the decision actually means. We have to be clear about what are the different alternatives where these decision makers or the participants in our study have to make trade-offs in between these different scenarios. What we usually try to prevent is framing effects. We don't want to trick our participants into a certain wrong decision making processes. So we want to avoid positive or negative framing of these objects. So to be more precise for decision objects in health reference research, these objects can represent a healthcare intervention, a treatment. They can represent policies or health states of an individual where participants of a study can make choices or trade off certain attributes or items. Attributes and levels can be defined in short as characteristics for treatments relating to efficacy or side effects. And the levels do represent the range of those attributes. So for example, if we have a risk attribute, which is focusing or documenting a side effect of a certain treatment, we could state that there is a 5%, a 10%, a 20% risk of these side effects. The most important thing, or what we're trying to do in setting up these experiments or questionnaires, surveys, or even interviews for qualitative studies, to be clear, consistent, to define attributes and levels in a transparent manner, so that we can ensure that we're actually eliciting valid preferences of the people we're asking, interviewing, or surveying. Identifying attributes and levels as the core of that decision model, or later, and I'm going to explain this, decision descriptive framework, we have lots of methods at hand in order to explore preferences, in order to gain insights on what's valuable to our participants or the underlying population. So most of the time we start off with a literature review, looking at the potential list of attributes and levels which were done or used in the past within experiments or qualitative or quantitative research. We then can move to interviews, asking, for example, patients directly what's of matter to them, what trade-offs are crucial within their past, what experience they lived through, or we can discuss these issues with focus groups. And all of these methods do have their pros and cons. And then we even can move a step further to use different, maybe more elaborate elicitation methods, doing surveys in front of a health reference study, asking participants to rank and rate certain attributes. That's mostly done to narrow down a large list of characteristics of a treatment or items of a certain health states to the most valuable or the most interesting, or the ones we should focus on in health reference research. And we also could do a factor analysis, for example, and more elaborate quantitative techniques to get more information of what's valuable, what's important, and how these different attributes and their levels do interact with each other. And there is a very interesting paper written by Sokai looking at the large array of these different methods to explore preferences in certain groups. They came up with a different with a setup doing individual methods, using semi-structured interviews, in-depth interviews, even complaint procedures in real life can be introduced. There could be a large potential methods for group methods, starting with Delphi methods, or the nominal group technique, which was used previously in some papers. Also, the preference could be explored in public meetings or citizen juries. And then all of these different individual or group techniques can be used together to come up with a very individualistic concept on how to explore preferences, more precise attributes, their levels, and the setting these attributes and levels are being introduced to the participant or decision makers. So here I have a few examples, and they're very basic. These are examples of continuous and categorical attributes. The continuous ones could be waiting time, 10 minutes, 20 minutes, 30 minutes, out-of-pocket cost, $5, $10, $15, risk of side effects, either 10 out of 100, 5 out of 100, or 1%, 10%, 50%. Risk of poor outcomes, treatment duration measured in time, and costs. Examples for categorical attributes are location of the hospital, rural areas, or in a town, in a large town, mode of medicine administration, either given oral or injection, type of healthcare professional, nurse, nursing staff, clinical staff, maybe non-clinical staff, and reputation of a healthcare provider. So that's the most basic distinction between continuous and categorical attributes. We discussed examples of attribute levels, and that's where it gets deeper and deeper into the rabbit hole. The easy one is waiting time, 1 week, 2 weeks, 3 weeks, out-of-pocket cost, risk of side effects. And I did explain the levels according to the attributes, for example, treatment duration, 1 month, 6 months, and 12 months. And I'm the location of the hospital, city center, rural areas, and the degree of side effects in here as categorical compared to the continuous one. Here, there are none, mild, moderate, and severe. But also there's a discussion on how the associated levels of an attribute are actually linked to the perceived benefits or utility of these attributes and levels. And in most of the studies, they're assumed to be linear, that the more of an attribute you get, the higher the attribute in a constant manner, or the more you have of a bad or of a negative attribute, the lesser the lesser the utility or benefits are from this attribute. But this often doesn't reflect reality, because we have exponential dependencies of an attribute to utility. We might have sigmoid or tapering. And that's easiest explained with my very good haircut. And the more hair I would gain back, it's not said that linearity of the dependency of gaining hair back to the benefits I receive would be linear, because, if you would give half of my hair back, what would actually happen? It still would be called no hair. And therefore, I wouldn't get like 50% of the benefits back, because it still wouldn't look good. If I get 100% back, well, the hair would be 100%. There would be a high benefit, but maybe this could be an exponential function. Just at the end, I would gain the full benefits of having hair. That might be a basic example of explaining what's going on there. Another very interesting field is the question on how to communicate risk. We have different ways of presenting risk to a participant of a study or even to a patient within the decision-making framework. And that's why we can learn a lot from organizations like FDA or other regulatory decision makers who already thought about these problems on how to present risk. We do have the possibility of presenting percentages in our question survey or even qualitative questions. Percentages like 10% risk of side effects. We can present natural frequencies. 1 out of 10 experience a side effect. Or we even could go a step further and present graphical icons to show the probability of something happening within a certain setting visually. To move a little bit further, most of the time it's the combination of both, which is working within health reference research. So for the probability, for example, of demonstrating 10% of a risk of a side effect, we could show a risk grid where we have 1 red icon and 9 green icons to visually represent the same risk. And we also put in the text refer to 1 out of 10 patients would experience this specific side effect. So these are the different possibilities, and there's a large literature and many books written on how to present this. Here more picture, we can present probabilities deterministic, like no heart attack, mild heart attack, or then move to a more advanced risk grid, presenting the chances of a certain risk here, the chance of mild heart attacks with 0, 2% out of 1,000, or 20 out of 1,000, and 5% as 50 out of 1,000. The same thing could be done with 0, 2, like 2 out of 100 and 5 out of 100. We also can link the risk to a qualitative description, which is mostly done with medicines, pharmaceutical products, where side effect risks have to be communicated in a transparent and replicatable manner. So here we have the very common side effect greater than 1 to 100, common 1 in 10 to 1 in 100, less common, which would be 1 in 100 to 1 in 1,000, and then rare would be 1 in 1,000 to 1 in 10,000, and very rare would be considered less than 1 in 10,000. So that could be another way in order to document or present risks to a survey participant or to a participant in qualitative research. And even that can get more complicated. And I have to apologize by transferring this chart, which is out of a paper. I didn't put in the source. I'm going to do this once I give these slides to Matt, before I give the slides to Matt. So we have pictorial ways of presenting, qualitative descriptions, numerical descriptions, graphical, and even in there are more precise and specific ways of presenting different kinds of risk. Now I'm coming to the question on how to build a descriptive framework. And I first want to introduce the idea of a descriptive framework, or the question, why do I need one in health reference research? The descriptive framework can be understood as a table, a short description of the different pillars or necessary information you need for the decision model. So it often presents the attributes and levels, and the description and definition of these attributes and levels and how they're being used within the HPR study. So the question here is to how to structure the information for the participants of the study so that they clearly can understand the decision object, which is then built on the attributes and levels. And these attributes and levels then further can be defined and represented by graphics or icons or risk grids. So here we're combining a qualitative description of the decision criteria or indicators and the more quantitative information, which is then placed to each of the levels concerning of these attributes. So for example, if we use the example of the heart attack or risk of a heart attack, the attribute would be the risk. The levels would be 0%, 2%, and 5%. And we actually could add a visual aid of a pie chart showing the risk distribution of that specific level. And moving this a step further behind the descriptive framework, then there could be further information, either based on the hypotheses, the null hypotheses, which then would be the underlying assumption, or we even can move this within the descriptive framework a little further, where we actually have information in the descriptive framework about the interaction or the hypotheses of the interaction of different attributes and the concerning or their respective levels of these attributes. So what do I mean by that? If we would like to make a preference study about trousers or pants, the color could be associated with a different texture of the pants. So blue would be associated with denim jeans, and other more business pants or trousers would be associated with other different textures. So let's say a gray or black jeans would not be the same. It would not interact in the same way than blue with jeans. That's behind that. And all of this could be transparently discussed within the descriptive framework of a study. So coming to an end, which is pretty much an open end, discussing the basics of how to present an object to a subject in a study, we naturally run into quite a few problems. And they have to be further developed in the study. So the first one, and I tried to discuss this in the previous slide, are interaction effects of the attributes and their levels, and how they interact and affect decisions in complex ways, which then later can be not disentangled with basic methods, or maybe not even with advanced methods. So looking at interaction effects that can be discovered or analyzed within the statistical part of a study. It can be discussed in the qualitative part of the study, and it even can be introduced within the experimental design. For example, if you use an attribute which combines two different levels within one attribute. We can call this a compound attribute, for example, where we combine the question of how long somebody wants to live, depending on a certain depending on a specific side effect. So let's say if there's a worse or bad health state, that might interact with the benefit of the longevity of a certain treatment. Obviously, in these studies, multilinearity plays certain attributes, and that's gonna harm the reliability of the study. Even that, well, that was the wrong start of the sentence. This should be discussed at the start within the descriptive system. Maybe it cannot be sufficiently discussed within this phase of a health reference study, but if there is information about multicollinearity, it should be taken into account and it being introduced in the descriptive framework. We do have problems of information bias, either having not enough or sufficient information, or even having too much information on attributes and levels, and that could be concerning within the study design and could lead to inaccurate responses. We do have hypothetical bias. We have differences between what people are answering within surveys and qualitative research with hypothetical scenarios, and there might be differences to what they do in real life once they are confronted in reality with the same trade-offs. And if there are differences, the estimates of our preference research might not reflect reality, and everything we're trying to deduce for the future might be wrong. Things like starting point bias, like confronting participant with initial values, might influence the participants' perception of on attributes and levels, and therefore the decisions might be disproportionately and not reflect real decisions in real time. And also there's something like strategic bias when being asked to make a judgment or communicate preference. Respondents might be strategic about their responses and overemphasize certain aspects which are crucial or important to them. So the summary and future directions, real quick, because I have some of the questions which might be derived of the presentation itself in further slides. The key takeaways for this paper and this very basic introduction on how to present an object to subjects within health preference research is that we as researchers should put a lot of work into the decision modeling itself, understanding what the decision is being based in reality and how these decisions are being made. And that's certainly improving the quality of health preference research. We are all having problems or even, thinking about how to derive a certain set of attributes, how to identify attributes and their concerning levels, and what's critical, what's being needed for preference elicitation A lot of times we struggle with the number of attributes, trying too much and therefore hindering or harming the study because people cannot make decisions, or maybe forgetting or not using some of the most important attributes, which then leads to results which do not reflect reality. We have to look at framing and how we present attributes and levels and the whole decision making framework, because it does have influence on what our participants in the study tell us, what's important to them, how they're making their trade-offs. What does the future bring and what are the future needs for the research? And just to be real quick and very basic, it's the question of how to handle multicollinearity and interaction effects, and how we move further towards the biases which are introduced in real-world decision making to the kind of studies we do. And we have wonderful groups in around the world who constantly work on the task on how to do better stimulations in HPR, better stimulations when we have a subject and an object, and how we can observe these stimulations in a more transparent and maybe more reproducible manner. So I know I'm a little early, but maybe we have lots of questions. Thank you, Matt, for the chance to present. I know I forgot to introduce myself, so I'm going to do this here. My name is Axel Mühlbacher. I'm based in Germany. I'm a health economist interested in health reference research for a long time. I work with a wonderful group at Duke University, which is doing great research in this way. And I know there are some people here on this call, so saying hi. I was involved in the opera for a while on the board. A very interesting group of people who just had a meeting in Canada, which was very successful. And I'm involved in the task force that is for who's also doing work on health reference research. We're right now starting a new working group on heterogeneity in health assessment. Thank you very much for your time. And I'm going to stop
Thanks,
here.
Axel. No, that's great. Thanks very much. I'm sure, yeah, you could probably hear the round of applause going on as we sit here, but everyone's on mute. So thanks very much for the presentation. I see Bennett put one question in the chat already. So maybe we start off with that one, and please feel free to add more. I'll read it to you, Axel, so you can think about it as I read it rather than reading it yourself. Bennett says, does anyone have examples where they did a preference study using one kind of attribute, for example, probabilistic, and realized afterwards that a different type, e.g. deterministic, would have worked better? Or when you've used one definition of an attribute and later realized it maybe didn't work. So maybe you used mild, moderate, or severe, and people didn't really understand it, and you should have used some other sort of presentation. Do you have any experience with that, Axel, that you'd like to comment on?
That's a difficult question, and thank you, Bennett, for asking. And obviously, I would be lying saying that there are multiple examples where I experienced that an attribute would have worked better after the study was being done. We do have free testing where we experience that different ways of presenting levels lead to different answers. So within the pre-testing phase, we do pre-test different kinds of levels, but that's not being published. But I assume Bennett wants to address something different, that it would be great we would know beforehand how different attributes and their levels work. We do have lots of experiences. We have lots of good researchers and lots of good research studies where different attributes were already tried out, being presented to the same group of people, let's say a certain patient population. And it would be great if we have had something like a, a bank, a registry of these attributes and levels where researchers could first easily take a look on what has been used in that population, and second, what were the experiences of these research studies, and what can I learn right at the face of the literature review, and what kind. And now we're moving towards the phase where we can validate our own studies in the future. If I can replicate the results within a certain health reference study, which was where a certain attribute was being used in the past. I hope, Bennett, that
Go
was the
ahead, Bennett.
answer.
Hi, can you hear?
Yeah.
So I'll mention two things. One, here's an example of something June, Yuan, and I did. When we were early in our preference work for cardiovascular, we decided to make the attributes match exactly the definitions used in clinical trials. So for bleeding, there's something called ISTH major bleeding and ISTH non-major clinically relevant bleeding, and they're rigorously defined. And we said, great, we're going to use exactly those definitions. Well, what happens is those are really composites. They're very broad. So even though it's one word, major bleeding, it could be death and stroke, and it could go all the way down to hemoglobin reductions that don't have sequelae. Non-major clinically relevant bleeding has a huge range of manifestations. So we ended up having such a broad definition for these that some people sort of glommed onto the scary part, some people glommed onto the mild part, and we introduced noise. And in retrospect, I think we would have been better off picking one exemplar of a type of bleed that's sort of in the middle or the modal distribution and introduce less noise. That's an example of something I learned from.
Just to follow up on that, Bennett, it's really interesting because so you would normally pick a clinical trial definition if you were going to a regulator, say. Do you have experience of what a regulator might think of picking an example, the midpoint like that to represent a concept?
The experience I've had to date is they tend to move towards the broader definition, which I think it could be a mistake. I think that noise is much worse than the cost of picking a precise definition. Basically, this is something that Reed Johnson likes to say. It's better to learn a lot, about a little than a little about a lot. It's better to know exactly what you've learned, even if it's not exactly the problem you want, than to try to get the problem you want and then not know if you really have it. But I do think the regulators that I've spoken to tend to move in the direction of wanting to have the broader definition.
So a question back. How come you didn't detect the problem with that attribute in pre-testing?
I think in pre-testing, all of the discussions with the small number of people, I don't recall if it was 10 or so, sort of seemed to work. I didn't do the pre-testing myself. It was done with a vendor we worked with. I think we didn't hear them saying, "Oh, I'm worried about this manifestation of bleeding. I'm very frightened of it." But you're right; it should come out in pre-testing in theory.
Yeah.
But sometimes I'm thinking it could be subtle. Or what if everybody focused on the scary part of the bleeding and it looked consistent when you did pre-testing, not realizing you'd have to be a bleeding expert that, oh, they were looking at the scary part and not the more typical definition.
Yeah. I think that's a good example for once you start cranking these studies through and through, just throwing quick in the definition and using it. It can be quite time consuming and expensive to do the pre-testing and then iteratively going through and trying to find out how and what kind of information you get once you use these different attributes.
The other point I just wanted to mention is the Medical Device Innovation Consortium's Science of Patient Input project is working in part with IOPR on a preliminary attempt at a library of attributes from published literature. there's a lot of steps ahead, but it could move in the direction you just outlined, Axel.
Yeah, it's been, I mean, there was even at Value in Health, there was this discussion about having these attribute banks. I'm aware of how registry might help to move this a little further. It's going to be an interesting field.
Thanks very much. Cecilia, I can see you've asked a really interesting question in the chat. Would you like to unmute and ask it in person?
Yeah, hi, thank you. Sorry, I was waiting for the discussion to take place. But I ask, and I think it has to be with what you have been commenting. So from my experience with patient-reported outcomes, there was always this trend to move to rushed analysis or rush model-based PROs. And what these PROs help is that they determined usually just three levels, and where they kind of like has more chances of having a real hierarchy between the responses, and they propose that there's the same probability for one participant to fall with each category. And I have been kind of like trying to push the idea that if you are going to use categorical variables, like when presenting symptoms and so on, and where PROs can be informative to how to phrase these attributes and levels, that using Rash-based PROs could be a good alternative because of the way that these have been validated and the way these have been refined already. So there has been loads of like research behind to kind of like help support that one category, middle category, and top end category have the same distance in between. But I don't know if any of you have experience implementing this type of PROs, or how do you choose a PRO when you are using this to inform your levels?
I personally do not. I do not have a study or a paper on using a rash model in order to look at the levels of certain attributes. I'm aware of how it's being used in PRO. And I think it's a good way to move forward in how to use health reference studies, especially in health and in patient-reported outcomes. There it could be really helpful.
Thank you both. Daniela, you've asked a question in the chat. Would you like to unmute and talk to it in person?
I can.
Thank you.
Thank you for a very interesting presentation and this interaction. Perhaps it's a little bit related to Cecilia's question. In our case, it's actually not the patient, the hypothetical study. It's about having prevention methods related to safety of pedestrians and bike riders. And we design our hypothetical case with different attributes for the prevention method or the safety device. And we randomize the assignments with two different risks. But it seems that the respondents totally ignore the risk. It is only, regardless what we give to them, it seems that they ignore the risk. And that is my question, if the introduction was clear. Do you have any suggestion how we could think of a better way of designing that differentiate between the device attributes and the risk? Thank you.
One question first. Are they not looking at the risks? So are they not paying attention? Or are they recoding the risk to low, middle, and high risk? So no matter what kind of numbers you put in, there's still a coefficient which sort of presents low, middle, and high, or is the information about risk not being taken into account when they make the decision?
We did this exercise. We did, like you suggested to us, to test, but we test with students of economics, which seems that they understand risk much better than the average voter, to say so, or
Yeah.
the median voter. And we gave not low high, we say like 1% reduction versus 5% reduction. And it seems that and this was, we change, they repeat the exercise. And regardless what they receive in the first assignment, it seems that they react, but regardless if it is 1% or 5% reduction. And we are not sure because we are doing for the first time this kind of studies, and we try to follow the theoretical background and so on. But the results what we got made us, we think that we did something less good about that. That is the reason I'm asking the question. Thank you.
I'll give you two things you might want to try. The first is a risk tutorial. You can train within the survey people and explain how you use risk. You can explain how the risk grid works, and you can ask them some training question, and that might do a difference in how they respond and if they incorporate this information. Second, there could be something like a scope test, and that would be a solution or a test regarding the problem that they recode the information you give them, if you have like the levels 1, 5, or 10%, but they're not taking the 10% into account. They just recode this to a high risk. And then you could do a scope test where you change the last level, let's say the 10%, you separate your survey into two populations, and then you change the last level to 10 or to 20 and to 20. And if they react to 10 and 20 as information, the coefficient of 20 is going to be higher than of 10. And then you can compare. At least you cannot prevent, but you can test if that's a problem or not. Maybe you want to do this in pre-testing.
We did a scope, but the coefficient is not statistically significant. And that was actually mostly my concern now.
Okay.
But I don't want to take more time if it is not of interest for the rest of our audience. Thank you a lot, Axel.
You're welcome.
Thanks, Daniela. So Deborah's got a question on your limitations, Axel, and I've also got a question on your limitation slide, I think a couple before where you are now. So Deborah, forgive me, I'm going to use chair's prerogative to ask mine first, and then I'll come to yours. So when we're designing our studies, I think we've all faced, well, if you've designed one DCE, you would have had to make a decision where actually you have to make a trade-off about which one of these you accept to some extent. So for example, conceptual correlation between attributes. Sometimes we accept a little bit of conceptual correlation between attributes if those two things are really important. You know, some DCEs include overall survival and progression-free survival, for example. So I wonder, Axel, if you could describe, you know, some of the trade-offs you make in relaxing your concerns about a couple of these limitations, or decisions you've made where you've prioritized other aspects and accepted a limitation in the method.
Well, most of the times we do accept the correlation. There's hardly a study which doesn't have that correlation. And I think the answer is more basic. It's not that, you know, there's a certain degree of acceptance. It's having the pre-testing, and then after the pre-testing relying on the analysis and just finding a way. I think with collinearity and interactions, it's more about knowing exact where these problems arise than having a perfect way of preventing these problems.
Thanks. And Deborah, are you able to unmute and ask your question? Don't know if you're there.
Sure, if you want. It's just on that limitations. It was that limitation slide. I was sitting here reflecting, as we've had many discussions with many of the people on this call, you know, sure, recognizing the limitations is really important. And when we're planning and designing, it's absolutely critical to try to mitigate these as much as possible. I guess on the flip side, all of us have been in rooms with decision makers or with colleagues who don't do preferences work, and we've all seen the reports and guidance from the FDA. And one of the questions is about the validity of these studies in general. So I'm just thinking about how do you address this long list to adequately, I guess, reassure people that there is validity to the findings from this work when there's a long list of potential biases, and how we have people who are often skeptical about preferences, unlike all the people on this call who are positive usually about preferences and excited. You know what I mean?
Yeah. Talking to regulatory bodies, most of the time, or the most vulnerable critique was when we forgot to include a certain attribute. So its validity is most of the time challenged, especially in regulatory, about the completeness. And to get this one step further, a new problem, at least for me, which arises, is that demonstrating how a certain endpoint can be patient relevant. And that not only can be done by, if there's a positive coefficient, we have to demonstrating that within a mixed method approach, which is built on top of each other, we can describe how we ended up with a certain list of attributes, which in basics, we call it triangulation. Doesn't have to be triangulation, can be more advanced methods like combining experts and patients' perspectives into a validation process. And I don't think there's, and you obviously know, you did in multiple ways. There's not the final and best way to demonstrate this. I think over the last 20 years, the most harmful discussions were when we had people in the room who said they knew how to do this. And often being confronted with these people half a year later or a year later, I found out now they do it totally differently. I think we have to do our best. We have to combine different methods. We have to be clear on how we move forward in order to come up with certain attributes, the lists and attributes and the levels. And then we can maybe validate afterwards once the study's being done, but that would be not addressing the topic we're having right now. So
Deborah, oh, sorry, I was just going to ask a follow-up to Deborah, if I can put you on the spot. I think you speak to many more decision makers than most of us. What are the key challenges you get, and what are your responses to those?
I don't know if I want to be put on the spot. I was just about to leave, but sorry, I'm actually double booked. But I guess it's a really good question, and actually, I would love this conversation because it does face us many times, and I'm not sure that I necessarily speak to more decision makers than many people on this phone. Probably Bennett and some others are more frequent flyers in that respect, but we do absolutely get questions on the appropriate population, about the validity of the methods, about the heterogeneity of the findings, and how does one interpret this in terms of the population. And they do ask questions around basic, I'm going to categorize it as trustworthiness, which sort of encompasses every aspect of how you design, execute, validate, and report preferences studies. So I think there is a lot of question around, how good these results are, and also then about the generalizability, because in one way, we essentially do a preferences study on every single study. So I think the work that we're doing with the MDIC around the library will help perhaps mitigate this, because we can improve some standardization of the attributes so that maybe it's not de novo every single time. So I think that's an important work, and Bennett mentioned that. And not having, 150 studies looking at diabetes, and they don't know how to sift through that because there's 150 preferences studies in diabetes, and they begin to wonder what the right, estimates are and if they're relevant in the context of the trials and the alignment. So I think these are the things when we talk about real world that become very apparent, and maybe Bennett or others may want to comment on this, but these are certainly issues that arise.
Thank you very much, Deborah. Bennett, I see your hand up.
Well, thank you. I actually welcome the list of concerns. If we are not upfront about them, others will push them upon us. And it also gives us, great grist for research. So I don't see the list of concerns or issues to address as a reason for others to question the research. I actually see that our acknowledging the potential limitations and the areas that could lead to bias are those in the field acknowledging it as a reason for those who contract with us or ask us to do this work to trust us. If we didn't acknowledge those, they'd have a fair reason to question us. And then the next step is, all right, what do we do about those? Some of the concerns, there are methods that for internal validity testing that help, that nothing's perfect. I think it's very much like other scientific fields where the goal is not perfection, because perfection is not possible. The goal is to demonstrate that you've used the best science possible and you've done as much checking as possible, and that the results that you get are informative enough to make the investment of time and resources worthwhile. Anyway, I do, and from now less theoretical point of view, yeah, we get a lot of questions. Are you biasing things by defining those things that way? What happens because you didn't include 400 attributes? Is your vignette somehow biasing things? And on and on. And we try to explain the approach we use and how we do pre-testing as much as possible to identify issues.
Thanks, Bennett. Thanks, Deborah. So, Axel, we just got a minute left. I wonder if you wanted to make any sort of closing remarks before we wrap up.
There's a closing remark, and maybe Deborah and Bennett and all the people I saw know, like 10 years or 20 years ago, we were presenting preference studies, and the most annoying thing was presenting at a conference, and there were people participating, and I said, forget about DCEs. I tried one, it didn't work. And then you took a look at their research, and they were just plugging in attributes and levels right out of the book and didn't explain what they were doing. They didn't have cheap talk. They didn't present a descriptive framework. And that was clear, it didn't work. And I'm so happy we're past that stage. I hardly get that comment. I hardly get that discussion. I thought it was so annoying like 10 years ago. Doesn't work. I don't like your research because I did one study and it didn't work. And we're past that. We're over the last 10 years, there were multiple initiatives on how to do certain things in health reference research. It probably takes another 10 years to getting better. There's no study which is perfect. We should stop listening to the ones we know it all type of researchers, pretending that they have the final say in how these studies are being done. We should more focus on the questions, on the answers we have to deliver once we communicate our results, and then we're on a good way on how this data is being implemented into decision frameworks in the future. And sometimes these are the basic questions like, like the slides today and the paper today, which are getting interesting, especially in more sophisticated studies for regulatories, etc., who actually come down to these basic questions and ask. And I'm so happy we left the stage of I did one study and it doesn't work, and I know how it has to be done kind of research, checklist papers, and we're past these stages, and we got a wonderful future ahead of us.
Well, that's a great note to finish on. Thanks, Axel. Thanks for the rallying call as well. Thank you everyone for joining to I Hear, IOPRA, and The Patient. We'll let everyone go now, but thank you again, Axel, from all of us.
Thank you very
for
much for
today.
inviting
Thanks
me.
for the conversation. Bye
Bye.
bye all.